Chapter 6 is the cardiovascular system, which is our topmost priority. Knowing the location of blood vessels, especially the most commonly used veins, composition of blood is essential to performing venipuncture. This chapter takes a deeper look into the cardiovascular system and its components and functions, as well as its impact on blood tests specifically done for the cardiovascular system. Now, the system comprises the heart, blood vessels, blood, and the system transports nutrients, gases, hormones throughout the body and transport waste to the appropriate system for excretion. A phlebotomist must understand the blood composition, blood circulation, function, and location. Starting with the heart. There are four chambers of the heart you see here, right and left atrium, and then right and left ventricle. If we take a section of the heart wall, we see there are three layers from inside to outside. The inner wall is endocardium, then myocardium is at the middle, the outer one will be epicardium. So endo, myo, and epicardium. Epicardium has two layers, visceral and parietal, and in between we have this pericardial fluid. So those are the layers of this heart wall. There are three types of circulation we find here. The coronary circulation provides blood supply to the heart muscle. Pulmonary circulation sends deoxygenated blood to lungs for oxygenation, sends this oxygenated blood back to heart. Systemic circulation sends oxygenated blood throughout the body and picks up nutrients and hormones. These are the coronary arteries you see here around the heart, those red lines. And then next picture shows coronary veins, those blue lines. So again, the coronary circulation will supply blood to the heart itself. The pulmonary circulation, pulmon means lungs, so the circulation will go to lungs and get back from there into the heart. So heart to lungs and lungs to heart, that will be pulmonary circulation. And this time the deoxygenated blood will be transported to lungs for gas exchange. Largest one and most important circulation will be this systemic circulation, carrying this oxygenated blood to every parts of the body except lungs, and then it will come back for oxygenation into the heart, right side of the heart. This one is important for you to know the difference between arterial and venous blood. Arterial blood is bright red because it contains oxyhemoglobin and is rich in oxygen, whereas venous blood is dark red because it contains deoxyhemoglobin and is oxygen poor. It contains a higher concentration of carbon dioxide than oxygen. So you see the difference between these two oxygenated and deoxygenated blood, that is arterial versus venous blood. Now, three types of blood vessels you see here. The red one, those are the arteries transporting blood away from the heart. The blue one is the vein that is going to bring it. Sorry about that. And in between, we have the capillaries. Capillaries are connecting arteries in veins. Now, the structural difference between these two, you will see that the layers in the wall of the arteries are thick, especially the middle layer is very thick, because artery has to carry blood under pressure, whereas in vein, this wall is very thin. So, first difference between artery and vein is that the wall is thicker in arteries, thinner in vein. Second thing is that arteries don't have any valve, but the veins do. Veins have those valves, maintaining the one-way direction of blood's flow. The efferent vessels, efferent means away, transports blood away from the heart. The arteries are efferent, carry blood under high pressure, elastic, muscular, thick-walled, and most carry oxygenated blood, which is bright red. In vein, that will be afferent, thinner wall. They will be deoxygenated blood mostly. It stores 65 to 70% of the total blood volume in our body, and it has valves, like you see there. Those are the valves controlling blood flow. Now, what about the capillaries? Capillaries are the smallest blood vessels, link arterioles to venules, site of all gas exchange, and thin walls are one cell thick to allow for gas and nutrient exchange. At a venipuncture site, a vein will feel bouncy, resilient, whereas the artery will feel firm and well pulsate. We'll apply this knowledge when we go for venipuncture, phlebotomy procedures. We'll have to find out the right vein at the right place. In case of accidental arterial puncture, what should we do? This is important to note that if we accidentally puncture arteries, first to withdraw the needle, apply pressure for at least 5 minutes, instruct patient to remain still, and notify a nurse to assist in hematoma prevention. Hematoma is a blood tumor just under the skin. It may happen uh, to accumulate, so we have to stop that. So these are the steps to follow if we accidentally stick arteries. Remember, as a phlebotomist, we are supposed to draw blood from veins, not from arteries. Now, what are the veins available for us in this area? First, to know that the area, the diamond shaped area on our elbow, the inner side of the elbow, this is called antecubital fossa, the inside of the elbow. Again, antecubital fossa, which is the most common site for phlebotomy. Median cubital vein, the largest and best anchored vein, that will be our first choice. Second choice will be cephalic vein. Uh, it is also well anchored, but harder to palpate sometimes. Third choice will be basilic. Easy to palpate, but it tends to roll. Also lies closer to the median nerve and brachial artery. So this is why we try to avoid these things. So remember the sequence. Your first choice will be median cubital, second choice cephalic, and third choice will be basilic vein. Two most common vein patterns are the H pattern and M pattern you see here in this picture. So that will be our most commonly used area for venipuncture. We can also use veins, the back of the hand, the dorsal arch, as you see. If the antecubital fossa, those veins are not accessible, we look for these veins which are smaller and more difficult to use. In this case, butterfly needles should be required. Phlebotomists should not use veins in the head, legs, or so these are the options: the antecubital fossa and back of the. After properly selecting a vein, uh, you should use proper phlebotomy techniques, avoid probing, Patients have been awarded millions of dollars in compensation for loss of function. So always follow proper techniques and nerve and never probe for pain, because if we do so, accidentally we can injure the nerves underneath. That can cause temporary or permanent loss of function and constitutes an act of negligence. Next topic is composition of blood. Now, blood has so many functions you see here in this list. It transports oxygen, nutrients, hormones, eliminates waste materials, maintains water balance, transports antibodies and protective substances throughout the body to attack pathogens, helps regulate body temperature and maintaining acid base balance. So, what does it contain? That's the point. Two major parts: cellular components and liquid components. So there are three types of cells we find in blood: erythrocyte, that is red blood cell, leukocyte, white blood cell, and platelets, that is the thrombocyte. Liquid component constitutes plasma, mostly water, 99%, and other solids dissolved in that. Now, those three cells, red cells and platelets, granulocytes, monocytes, they belong to the myeloid side, and lymphocytes, they originate from lymphoid cells. So, according to the origin, where they come from, just remember that lymphocytes like B and T lymphocytes, they originate from lymphoid stem cells. Rest of the cells are coming from myeloid stem cell. These lymphocyte, granulocyte, monocyte, these are different types of white cells. This is our red blood cell that makes our blood red. It starts the journey in bone marrow. Bone marrow is the factory, the red bone marrow, to make blood cells. And cells are biconcave. That means at the middle it is depressed. They have a lifespan of 120 days. For 4 months, these cells can survive, containing hemoglobin, deliver oxygen to cells, remove carbon dioxide from cells. One clinical condition we want to discuss here is called anemia. When there is abnormally low hemoglobin level and or decrease in red blood cell count, this condition is anemia. An means absence, emia means blood. Patients will have weakness, headache, pale skin color, difficulty breathing, and these are the things happening with anemia. Next condition of blood is jaundice, a yellow coloration of skin and eyes. Why is that happening? Because of elevated levels of bilirubin. Bilirubin is produced during the breakdown of red blood cell, which is processed in liver, deposited in intestine for elimination. Due to some types of anemia that causes RBCs to be destroyed prematurely, um, this is the condition called hemolysis, destruction of red blood cell. Sometimes in newborn, normally have a higher level of this bilirubin because their liver is not mature enough. Later on, this will be, things will be better after a few days and weeks. But sometimes they need treatment for this. For us as a phlebotomist, the bilirubin, when we collect blood for that, we have to remember that it is light sensitive and a special type of tubes should be used for this specimen. White blood cell, leukocyte. They are not confined to vascular space. That means they can leave the blood vessel going to outside with a process called diapedesis, the process of passing through the capillary walls to enter tissues. They also have a process of eating surrounding pathogens and destroying them. This is called phagocytosis. These cells are round and clear when not stained. Um, Usually 5,000 to 10,000 white blood cells per cubic millimeter. In case of infection, the number of white cells will increase. And leukemia is a condition when there is cancer affecting these cells. These white cells, we categorize them into two groups. On your left side, you see polymorphonuclear granulocyte, neutrophil, eosinophil, basophil. These three things belong there. Two other, the monocyte, lymphocyte, they belong to mononuclear categories. Most numerous white blood cells are the neutrophils, which has 3 or 4 lobes, perform phagocytosis, causes increase during bacterial infection or inflammation. In eosinophil, which are bilobe nucleus, perform phagocytosis and they destroy parasites. Their number increases during allergic reactions and parasitic infection. Basophils release histamine, heparin. So when there is chronic inflammation and during healing from infection, these numbers will increase. Monocytes, the largest type of white cell, it has a kidney-shaped nucleus, perform phagocytosis, and with chronic infection, these numbers will rise as well. Next cell is lymphocyte. Single round nucleus, two types of lymphocyte, B and T. During viral infections, these numbers will increase. Our last type of cell is the thrombocyte or platelet, which is the smallest element, and it comes from fragmentation of megakaryocyte. They live only 9 to 12 days and help prevent blood loss. Whenever we are bleeding, they stop bleeding uh, through the process of coagulation. So they play a vital role. After the cells, then comes the liquid part. You see here, the liquid portion of the unclotted blood is called plasma. If it is clotted, then it will become serum. Pale yellow, mostly water, contains several important solutes. So again, the point to note, if the blood is allowed to clot and then we separate, we get serum. If blood is not allowed to clot, then we get plasma. And the difference between these two, you can find it here. The difference between plasma and serum. Uh, you see fibrinogen is present in plasma, absent in serum. And yeah, mostly that's the main difference between these two. The second thing is whether it is clotted or unclotted. Safety of immunocompromised patients. Think about HIV/AIDS patient who is immunocompromised. They have decreased capacity to fight infection. White blood cell count is low in these patients, which require extra measures to prevent infection. Standard precautions, hand hygiene, PPE must be used for these patients. and patients may be in a protective isolation room. Now, hemostasis. Hemo means blood, stasis means to stop. So, stoppage of bleeding. So, stop flow of blood from injury. That is the term we use here, hemostasis, which involves four major events: blood vessel spasm, vasoconstriction, platelet plug formation, coagulation, and fibrinolysis. Let's take a look in detail on those four major events of blood clot formation or stoppage of bleeding, hemostasis. First step, there will be vasoconstriction. You see here on the right side of the blood vessel, the cells are coming out. There was bleeding. So at the bleeding point, the vessel wall will be narrowed. This is called vasoconstriction. That is the first thing to happen. And this decrease of diameter decreases the amount of blood flowing through that area. And if the vessel is small, injury is limited, this alone may stop this bleeding. Step two, if the vasoconstriction is not enough to stop, the blood vessel releases chemical signals. Signals to call platelets to the injury site. Platelets begin to cluster on the site of injury and clump together to form a platelet plug. This process is known as primary hemostasis. Okay? So platelet will make a plug over there area. Step three, coagulation or blood clotting. Third step, it requires the presence of specific clotting factors to form a clot. The clotting factors come together and form thrombin, an enzyme that converts fibrinogen into fibrin. The fibrin adheres to the injury site, trapping blood vessels and other particles to form a clot. This process is known as secondary uh, hemostasis. Now, the fourth and final step is fibrinolysis. The clot formation stimulates the growth of fibroblasts and smooth muscle cells to repair the blood vessels. As the wall becomes more stable, the fibrin begins to break down in the process of fibrinolysis. This results in the dissolution of the clot, which returns the blood vessels to its normal state. Uh, this is the cascade, the waterfall cascade. It explains this whole thing. Um, it is showing in detail how the clotting process is done, intrinsic, extrinsic, common pathway, and that will be in detail just in case you are interested to learn every step. You find it here in those detailed part of step 3 and 4. Now, what happens if someone is lacking clotting factors? Some patients must be monitored closely following venipuncture if they are on anticoagulant. Anticoagulants are known as blood thinner, like warfarin, heparin, coumadin. So that's one type of patient. Other patient is who is lacking natural clotting ability, like hemophilia. In that case, apply manual pressure for minimum of 3 to 5 minutes. Ensure that bleeding has stopped. Now the blood type, ABO and RH type of blood. Blood types are classified according to the presence of antigen on the surface of the red blood cells and antigens in plasma. substance that causes the formation of antibody known as antigen, and in response to antigen our body makes antibody. If antigens on the red blood cells bind to the antibodies in the plasma, agglutination or clumping will occur. Again, antigen in the red cell, antibody in the plasma, if they bind, this process is known as agglutination or clumping. Type A, antigen A on the red blood cell, type antibody B in the plasma. So if my blood group is type A, that means I have antigen A on the cell and antibody B in plasma. If someone is on type B, he or she has antigen type B and antibody A in plasma. Another person with type AB, they have both antigen, no antibodies. The last person with a type O, that person will have no antigen but both antibodies in plasma. And this is what we do to find out the blood type. On a slide, we place a few drops of blood there, and with the antiserum that contains antibodies A and B, we add them on the patient's blood sample. If it makes this um, agglutination process, then we know that it's reacting with that blood, and this is how we determine their blood type. Say, for example, the first one, the first blood type A, uh, this blood will clump with anti-A antibodies, not with anti-B, that you can see in the first picture. Or look at the last one, blood type O. There is no clumping. So that means it is blood type O. So just in a few minutes' time, you can identify what type of blood the patient is having with this process of agglutination. This is the chart that we use for the ABO compatibility and which type of patients can donate or accept blood types from other person. This is the chart to note. The second type of blood is called Rh factor, Rh positive and Rh negative. Okay. Rh stands for rhesus. Rh on the slides refer to the type of antiserum like anti-D applied to the blood sample. If the patient has Rh antigen, that will react. Originally, it was found in a certain type of monkeys called rhesus, so we use this word Rh for that. People who are Rh positive, they have this antigen D on their RBCs. This is an additional things to the ABO type. Uh, Antiserum containing antibody D is used to determine this Rh factor. Rh positive blood clumps in the presence of anti-D antibodies. Rh negative blood does not clump in the presence of anti-D antibodies. And clinically, it is very important for a female to know her Rh type if she becomes pregnant. O negative blood is truly the universal donor because it has no A, B, or D antigens that can cause the recipient to form antibodies. Now, what happens if a patient is transfused with a blood that contains antigen to which he or she has an antibody? In that case, there will be complications. Agglutination or clumping will occur. If not reversed, this agglutination is followed by hemolysis, the destruction of red blood cells. Even in emergencies, patient blood is typed and cross-matched to avoid this transfusion reaction. Okay. Clinically, it is very important for a female to know her Rh type if she becomes pregnant. If needed, with Rh mother, negative mother, antigen D is given so that there should not be any complication if the mother is carrying Rh positive baby. So in this very important chapter 6, we discussed mainly cardiovascular system, um, different structures, and discussed some important topics about blood components. So if you have any question, please let me know. One second. Marcel, please, can I talk to you, Marcel?
Yes, Professor.
I see you are in the Teams. The text, I'm not sure. What is happening?
It's my connect. I cannot log in. I enter my email and my password, but
Log
it's
in
still
where?
not
Log into what?
to log into my connect.
Oh, you were talking about Connect, but you are in Teams right now, okay? Yeah.
Yes.
So when you did you use the link in Moodle for that?
Yes.
Okay, hold on. Give me a second. I'm going to check.
I was just having the same problem. I had to change my whole passcode
Uh-huh.
to log back in.
1 second. I'm going to open Connect from my side. Okay, so Marcel and Linda, I see that you are have account in Connect and already completed 3 assignments from last week. All right. So if you have difficulty entering right now, maybe try over with a different computer, or sometimes the Connect can be a little bit showing some glitch. So wait for a while and try again. Even if not working after like tomorrow or the day after, call the. I mean, you can call the customer service today. Actually, that's the best idea if you want to take your first test. Okay.
Okay.
But
Thank
so
you.
from my side, I see everything is good. You are have already started your account and activities are there.
Okay. I will try.
All right.
Thank you, Professor.
You're welcome. Okay, so this is what we'll be doing now. First thing first, the test one in Connect Week 2. This is on chapter 1, 2, 3, uh, which we studied last week. So chapter 1, 2, and 3, the test is now open for you. Let's get it done with. And then if have some time to work on the assignments for this week, yes, you can do it in Connect. Discussion forum is not needed for this course, even though I will post it there, but you don't have to do that. You can skip it. It is not graded. I'll take your attendance at around 12:30 p.m. Stay with me until end of the class. Next week we have week 3 lab work, and as you know that this is all these lab competencies are must to pass this course. We must complete 15 venipuncture and 15 dermal punctures by week 6. One more thing, those who have already purchased this NHA package, I think you can work on your NHA study guide. Those who did not, please complete the purchase for NHA. This is for your exam, the board exam on week 8. Anybody need with the NHA package help? Just talk to me.
Yes, Professor, I need some help with it.
Yes, Florence, what is it?
Um, I um, I have an account already, but I went in, but I did not see where the phlebotomy is.
Okay, can you try? You'll find my name, Dr. Mahmood, MA200 M3. That course is CPT. Let's try again.
So sign into the NHA account.
Yes.
Okay.
If you want, you can share your screen with me.
I am doing it on my phone. Professor,
Yes.
I'm on the NHA page.
Okay,
Where
so
and I can see where I did
yeah, can I see
the
your screen, please?
I did it on my phone, Professor. I didn't do it on the
Um,
computer.
do you
Um,
see the course with my name, Dr. Mahmood, MA200 M3?